Welcome, clinicians. Let's jump right into part one of our four-part explainer series. This explainer is based on the fantastic review BPPV, Recognizing and Treating All Canal Variants, Posterior, Horizontal, Anterior, and Atypical Presentations, published by Australian Dizziness Clinics. We are going to be exploring exactly how to recognize and treat all BPPV canal variants with absolute precision. So let's drop right into the clinic with a classic scenario, okay? A patient rolls over in bed, and suddenly they feel the room spin for about 30 seconds. Are we looking at a posterior or horizontal canal variant? Well, the difference between executing an EPLI and a BBQ roll begins with one fundamental diagnostic decision, recognizing the specific canal involved right at session one. Here's the clinical diagnostic funnel we'll use today. We'll cover the ultimate bedside cure, the three canals and their distribution, symptom patterns by variant, and finally, identifying the central mimic. It's a rapid, reliable framework to get you recognizing BPPV variants before you even think about starting diagnostic maneuvers. All right, starting with section one, the ultimate bedside cure. This is all about high-yield resolution in vestibular medicine. You know, BPPV is literally the highest yield bedside cure we have in vestibular medicine. It's the most common cause of vertigo out there, making up 20 to 30% of all cases, and that number spikes up to 50% in older adults, over 60. And as the Australian Dizziness Clinics emphasizes, it is remarkably treatable. We're talking 80 to 90% of cases achieving symptom resolution with just a single maneuver. 2 to 3 sessions, you're at near 100% success. But crazy enough, despite being so prevalent and so treatable, it's frequently undertreated. Way too often, patients are just handed suppressive medications instead of getting the curative repositioning therapy they actually need. Let's move right along to section two, three canals and distribution, focusing on anatomy and probability. So the pathology here starts with otoconia mechanics. We're talking about these tiny calcium carbonate crystals, roughly 3 to 30 micrometers, normally embedded within the utricle and saccule. Usually, they're doing a great job detecting linear acceleration and gravity, but they've got a finite lifespan. Thanks to age, head trauma, or maybe prior vestibular inflammation, these crystals can basically dislodge. And once they're free, they are entirely at the mercy of gravity. They migrate into the three orthogonal semicircular canals, creating this abnormous fluid movement that bends the stereocilia, and boom, you get that pathological nystagmus. Now, the anatomy directly dictates our clinical probabilities here. If you look at the distribution, it heavily favors the posterior canal at roughly 85%. And why is that? Well, physically, the posterior canal is the most gravity dependent. It's literally the lowest point whether you're supine or upright. The horizontal canal catches about 10% of cases, while the anterior canal, which is anatomically the least dependent, is only involved in about 1 to 2% of cases. Which brings us to section 3, symptom patterns by variant. This is where we use mechanical clues for pattern recognition. This decision diamond is super helpful because it provides a visual map of the whole diagnostic funnel. It branches from your presenting patient straight down to the 4 possible variant pathways: posterior, horizontal, anterior, and atypical. The huge takeaway here is that before you ever perform a Dix-Hallpike or a supine roll, the patient's symptom history is already guiding you down one of these specific branches. Contrasting these symptom patterns side by side makes the mechanical differences really jump out. Posterior canal BPV typically hits with a brief vertigo when looking up, rolling, or lying down. It's got a classic 3 to 10 second latency and fatiguing nystagmus. Horizontal, on the other hand, is heavily triggered by rolling over in bed and tends to last longer. Then you have the anterior canal BPV, which again is incredibly rare, might be provoked by head extension, and presents with a really atypical downbeating nystagmus. So the absolutely crucial thing to remember for the posterior canal is that delayed onset, that latency of 3 to 10 seconds before the nystagmus and vertigo kick in. That is a cardinal mechanical feature of the crystals moving through the endolymph. Here is a major clinical pearl for you. If your patient reports immediate vertigo the second they move, but there's no observable nystagmus, you really need to be thinking about anxiety or hyperventilation rather than true mechanical BPPV. Moving on to the horizontal canal flags. If a patient keeps emphasizing that rolling in bed is their main trigger, you've got to be on high alert for 2 distinct nystagmus patterns during your supine roll test. First is geotropic, where the nystagmus beats toward the undermost gravity-dependent ear. That tells us we're dealing with canalithiasis, or free-floating particles. The second pattern is apogeotropic. That's when it beats away from the undermost ear, pointing to capulolithiasis, meaning those particles have actually adhered to the cupula. Knowing this distinction is going to completely dictate your treatment choice later. Now, regarding the anterior canal, because it's anatomically the least dependent, getting involvement here is exceptionally rare. Often, it's just migrated debris from another canal, and frankly, it's very frequently misidentified by clinicians who mistake the torsional component of posterior BPPV for a vertical direction. Because of that, if you ever suspect anterior canal involvement, a very careful examination and possibly even a VNG is absolutely warranted before you try to treat it. All right, finally, we're at Section 4, Identifying the Central Mimic, where we cover the strict criteria for red flags. Following our diagnostic tree all the way down, you hit this bottom red warning. Atypical multi-canal presentations or bizarre nystagmus patterns require incredibly strict observation rules. Because, our job isn't just to find the right canal, it's to confirm we are safely within the bounds of a peripheral mechanical vestibular disorder. This right here is your strict clinical stop sign. True BPV features fatiguing nystagmus that typically resolves in under 60 seconds as the particles settle down. But if you see persistent, non-fatiguing, direction-changing, or pure vertical nystagmus that lasts past that 60-second mark, that is a central mimic. You must pause immediately and refer that patient straight to a vestibular physician or neurologist. So let's summarize our key takeaways from Part 1. Really, anatomy is destiny here. The distribution is roughly 85% posterior, 10% horizontal, and 1 to 2% anterior. Carefully logging symptom triggers is going to reliably separate those mechanical variants for you before you even start testing. And crucially, applying that 60-second rule with vertical or direction-changing nystagmus is what protects your patient from unrecognized central mimics. Okay, so you now understand the anatomy, you know the variant symptom patterns, and you are well aware of the red flags. But how exactly do you provoke and interpret the nystagmus safely in the clinic? How do you reliably trigger and differentiate that geotropic versus apogeotropic response we were just talking about? Well, that's exactly what's coming up. In Part 2 of this explainer series, we'll be covering the diagnostic maneuvers themselves, the exact technique and interpretation for the Dix-Hallpike and the supine roll. To access the full review and continue mastering this bedside cure, make sure to visit AustralianDizzinessClinics.com. Please subscribe and rate this explainer. Until then, ask yourself, the next time a patient reports a spin, will you be ready to trace the mechanics before they even sit on the table?